Good afternoon. It is a pleasure to welcome you on behalf of the ESTS Learning Affairs Committee to the 22-23 series of the ESTS webinars. This series of webinars has been established in 2018, and Lieven de Buper so far was one of the driving forces, and I would like to thank him for an excellent handover and look forward to moderate the upcoming webinars now. I think we've put together an interesting program for the upcoming webinars, and one of the hot topics certainly now is the topic of sublobar resection with the JCOG and the Alliance trials and also the smaller trial from German-speaking countries now after publication. And it is really a great pleasure to have Dominique Gossot from Paris, who is one of the segmentectomy experts of the first hour today to present his view in the webinar. He already published in 2011 on video thoracoscopic segmentectomies, and this was really a pioneering work. And it is a great pleasure that we have more than 800 registered participants for the webinar. And I'm really looking forward to an interesting lecture, and interactive discussions and discussion contributions in the chat are always welcome. So much for the introduction for now, and Dominique, the floor is yours, and we're really looking forward to hearing your presentation.
Okay, good evening. I'm really impressed that about 800 people are connected. So I hope it will be interesting. So I'm sharing my screen. Did you get my screen?
Yes, it's perfectly fine.
Oh, okay. I have some strange noise coming. I don't know where it does come from. Okay, so here are my disclosures. So this webinar will be dedicated to the results and the comments about the JCOG and CALGB trials. And when I prepared my slides, I realized that the topic was really hot and important. And unfortunately, we will have no place to discuss other interesting points related with sublobar resection, that is preservation of pulmonary function. Anyway, I've prepared a couple of slides if ever we have time for questions about this topic. I will not deal with morbidity and about technical aspects. So before starting, just a short survey for those people who don't know so much the papers about the JCOG and CALGB trial. So in the JCOG 0802 trial, which of these statements are right? So you have here the statements. Segmentectomy and lobectomy have equivalent overall survival. Segmentectomy has a significantly better overall survival than lobectomy. About recurrences, segmentectomy and lobectomy have an equivalent rate, or segmentectomy has a significantly higher recurrence rate than lobectomy. And regarding morbidity, is it equivalent, or does segmentectomy has a higher postoperative morbidity? So here are the 6 statements, waiting for your answers.
Okay, the poll is published, and you should have the option of answering now, and also there's the possibility that several answers are correct.
Yes, of course.
So we're getting in the votes. So for now, there's 27% saying that segmentectomy and lobectomy have equivalent overall survival. 24% segmentectomy has a significantly higher recurrence rate than lobectomy. 21% segmentectomy and lobectomy have equivalent postoperative morbidity rates. 14% segmentectomy has a significantly better OS than lobectomy. 12% segmentectomy and lobectomy have equivalent recurrence rates, and 5% segmentectomy has a significantly higher postoperative morbidity than lobectomy.
So the answers are these ones, and we will see the answers in more details. So segmentectomy, according to the JCOG trial, has a significantly better overall survival. The recurrence rate of segmentectomy is higher, and the morbidity rate is about the same. So let's start with this brief history that is useful to understand the changes. So we have to remember that for several years, pneumonectomy has been the gold standard for the treatment of lung cancer. And it's only in 1962, that lobectomy became the gold standard. So pneumonectomy was the standard, then lobectomy, especially after the trial that was published by the Lung Cancer Study Group in 1995. And for since the years 2010, a couple of papers have shown that segmentectomy might be equivalent to lobectomy, but it's only this year that segmentectomy has been proven to be superior to lobectomy in terms of overall survival. And the really new problem is the results of the CALGB, suggesting that wedge could be an option in early stage lung cancer. So this appears in a context where we know that lung screening programs have very good results, and it is expected that in the forthcoming years, the stage 1 and 2 lung cancer will be about 80%. Just an illustration coming from the Shanghai Pulmonary Hospital, showing that there are more and more self-referred screening, and this leads to a decrease in the tumor size and a raise of the proportion of stage 1 lung cancer. Accordingly, the lobectomy is decreasing, segmentectomy and also wedge resection are increasing. So a word about the CALGB 140503 trial, whose results were presented in Vienna in August. And so this trial has enrolled almost 700 patients for CT1A and 0 peripheral cancer. And what is original in this trial, that wedge or segmentectomy was left at surgeon discretion. So the result is that about 60% of the procedures were wedges. The follow-up was about 5 years. Just a word to say that there is some question about this trial, because according to the same team and to this paper that was published by the team of Nasser Al-Torki not so long ago in 2019, showing that for stage 1 lung cancer that were detected by a lung screening program, only 30% were operated by VETs, and only 5% had segmentectomy, while 11% had wedge resection, which is very different from what is done in Europe or, for instance, in Japan. So the results of the CALGB trial is that there is no difference in terms of disease-free and overall survival. There is a high rate of local recurrences, not only in the Sublobar group, but also in the lobectomy group, which may also question the results of this trial. Now, we will focus on the JCOG 0802 trial that most of you probably know, but just to remember that more than 1,000 patients were enrolled. Most were stage 1A lung tumors with a mean diameter of 1.6 centimeter. All tumors were peripheral, and the ratio of ground glass and tumor was superior to 0.5. The follow-up was 7 years. So the main result of this trial is that the survival is significantly better in the segmentectomy arm compared to the lobectomy arm. And so, as you know, the results have been recently published in the Lancet, and the conclusion of the author is that these results indicate that segmentectomy should be the standard treatment instead of lobectomy for CT1A lung cancer, provided they are less than 2 centimeters with a ratio superior to 50%. The second main issue with the JCOG 082 trial is the high rate of recurrences in the segmentectomy arm, and we will discuss this later on. So the current situation at the time of this webinar is that we have two trials, the JCOG and CALGB. Regarding the JCOG, they say segmentectomy should be the standard because it has a better disease-free survival, a better overall survival. The complication rate is about the same, but there are more local recurrences. One important aspect of the JCOG and interesting result is that there is a better rate of reoperation for the patients who had a second cancer. I will give you the data. Now regarding the CALGB, they have mixed wedge and segments, so they concluded that sublobar resection should be the standard with a similar disease-free survival and overall survival. We are still waiting for the complication rate. I forgot to say that the final results most likely will be presented at the ESTS next March 2023. And the recurrence rate is similar. And of course, we are waiting about the analysis by subgroup between wedge resection and anatomical segmentectomies. Now, a word about the patients who have been reoperated for a second lung cancer. We had published this paper last year to say that the results in terms of survival were very good. And in the JCOG trial, 15% of the patients who have been followed developed a second cancer. What is interesting to note is that there were much more patients who could be reoperated on after segmentectomy than after a lobectomy. Now we come to the crucial point. It is the recurrence rate, which is significantly higher in the segmentectomy arm. So the question is it because recurrence is inherent to sublobar resection? In other words, if you perform a sublobar resection, you take the risk of having a local recurrence? Or is it because we are omitting some principles like having a R0 resection, analyzing the margins and the lymph nodes? So I will discuss all these points, and this is based on the experience of our hospital. We have performed a little bit more than 1,000 thoracoscopic anatomical segmentectomies, and the rate is between 40 and 50% of segmentectomies. So first question is the issue of lymph node dissection. So we come to the second pool. So for clinical T1A N0 non-small cell lung carcinoma, would you say that upstaging to N1 at final pathology is 5%, 10 to 15%, 15 to 30%, or superior to 30%?
Okay, you can now submit your votes. On the right lower hand side, there are bars, and you can switch from chat to polls and have the possibility to click there. There were some people submitting their answers through the chat last time, so please go to the polls and submit it there. So right now we have a clear majority for 10 to 15% with 65 or 66% of participants, 28% say 5%, 7%, 15 to 30%, and 2% more than 30%.
Yeah, so the participants are correct. It's between 10 and 15% depending on the publications. So what is the issue of lymph node dissection for sublobar resections? So we know that the lymphatics of the lung drain into the bronchopulmonary lymph nodes, which are at the bifurcation of the larger bronchi. This means that, for instance, if you are performing a segment 2 resection, here is the tumor in black, and you have this yellow lymph node at the foot of the bronchus. So this lymph node will be removed with a segment. But we don't know what happens with the other lymph nodes that are in the remaining lobe. And if ever they are metastatic, of course, theoretically, it could be a cause for a local or even distal recurrence. So you may say, well, this must not be so frequent. I will say you are wrong. This is frequent. According to this paper by Schmelzer and co-workers, discarded lymph nodes are found in about 90% on lobectomy specimens, and about 1/3 of these discarded lymph nodes are metastatic. So in patients who are classified PN0, actually some of them must be upstage. You see here the rate of upstaging from N0 to N1. And what is also very important, that in case of when there are more than 2 missed positive intrapulmonary lymph nodes, the risk of death from the cancer is multiplied by 5. And this has been found in other similar studies. So the rate of discarded lymph nodes, some of them being metastatic, is very important and has to be taken into consideration. So if we accept that there is probably a small risk of local recurrences from these missed lymph nodes, other factors of recurrences, and can we minimize the risk? So the paradox that we are experiencing right now in 2022 is that up till now, lobectomy has been considered superior to segmentectomy for these oncological criteria that are very well known and that I will not repeat. And in this phase 2, that means recently when we consider that segmentectomy is about the same than lobectomy, we not always apply the similar oncological criteria. So when we are performing a lobectomy, I think most of us perform a true anatomical resection and a lymph node dissection. But when we are performing a sublobar resection, it's not always obvious where it's a true anatomical segmentectomy or just a wedge, if there is a lymph node dissection and if the margins are analyzed. So I think there is a very important sentence in the paper published by our Japanese colleagues, is that segmentectomy should be defined as a resection with sufficient margins and lymph node assessment in which margin positive or nodal metastasis can be assessed during surgery. And in the department, we consider that they can't be assessed, they should be assessed during surgery. This paper is interesting because it shows what a segmentectomy or a sublobar resection is in reality. These data come from the SEER database and showing that on stage 1 non-small cell lung cancer, no lymph node was examined in about half of the wedge resection performed and 23 of segmentectomies. But actually, as you can see on our preliminary results that we published a couple of years ago in the Annals, some patients were converted to lobectomy because of invaded lymph node at frozen section. Just an example, this very small tumor, we had the preoperative diagnosis of adenocarcinoma. The patient was planned for a S8 segmentectomy. This is how the tumor did look like. We find this very small lymph node between the two segmental arteries. The lymph node was positive, and obviously the patient was converted into a lobectomy. And we had a similar case a couple of weeks ago, exactly the same. Here is the lymph node, which was positive at frozen section, and the patient was converted into a lobectomy. So you may say, okay, if you are right that it is important to examine the lymph nodes, yes, but you cannot examine all the lymph nodes that you find during surgery. So which one should be examined? I think it's very important to read this paper published in 2018 by Xiao and co-worker about what they call the adjacent lymph node. Adjacent lymph node means the lymph node that is at the foot of the segmental bronchus, the one in red. And if ever this lymph node is positive, is metastatic, this means that 40% of the what they call isolated lymph node, this means the distal lymph node, will also be positive. So we do consider that it's very important to examine this lymph node that is at the foot of the bronchus and switch to a lobectomy if ever this lymph node is positive. So in this series of this author, the rate of occult N1 was 9%. Other authors like Robinson and co-workers found a rate of 14% of occult N1, and most of these metastatic lymph nodes were peribronchial. This paper, I have not read it because it's not yet published. It's ahead of print, but it shows that there is an important difference in terms of survival. If you consider the patients who were treated for clinical N0 lung cancer by lobectomy or wedge resection, and if ever you find an stage PN1 or PN2, the overall survival is much better in the patients who had a lobectomy. So it's very important to remove these lymph nodes that are at the foot of the bronchus. Here it is during S3 segmentectomy. Anyway, you have to remove these lymph nodes because it eases the bronchus dissection. So you remove them, send them for frozen section, and if ever they are positive, you convert the segmentectomy to a lobectomy. Another point that poses some question regarding the treatment of clinical T1A N0 tumor by wedge resection is that it's admitted that it's very difficult or almost impossible to perform a true intersegmental lymph node dissection if you perform just a wedge. This means that the number of examined lymph nodes will be low, and we know from several studies that the number of retrieved lymph nodes has a major impact on survival. For instance, in this paper by Yenda Muri, the only prognostic factor for over 5-year overall survival was the number of lymph nodes examined. And of course, we all know that it is not really the number of lymph nodes that is important. It's the fact that if you have many lymph nodes, you have more chances to find positive lymph nodes, and these patients will have an adjuvant chemotherapy or immunotherapy, and that's why they have a better survival. What about the N2? Well, we know that even in clinical T1A or T1B N0 We have a small rate of N2, 3% in this study, so that's why we consider that an N2 dissection must also be performed. So here are a few examples of intersegmental lymph nodes that are found during segmentectomy, and you cannot go on with the segmentectomy. If you find those kind of lymph nodes, you must send them for frozen section, wait for the result, and convert to a lobectomy if ever they are positive. So why do we insist on frozen section? Because as this author, many people say, okay, if at final pathological examinations, lymph nodes are positive, the patient can be reoperated on for lobectomy. But from a practical standpoint, we know that it is almost never done. The patient is discharged on day 2 or day 3, and you get the final pathological report at 8 days or 15 days, and it's too late, and most likely the patient will not be reoperated on. So we agree with Xiao and colleagues to say that it does not cost so much time to perform a frozen section, and it is very important for the result and for the patient. Some say, well, the sensibility of frozen section is not that high. This is true. We know that the specificity is excellent. The sensibility is only 85%, but I say, as written by this author, it's better than nothing. So 85% is acceptable, and probably in the near future, with some new techniques, this rate will be improved up to 95%. So this is what I wanted to say about the issue of lymph nodes. The second one is the problem raised by the safety margins. And so this brings me to the third pool. So would you say that for lung cancer that is inferior to 2 centimeters, the safety margin should be at least 5 millimeter, 10 millimeter, 20 millimeter, or superior to the maximal diameter of the nodule?
Okay, the poll has been published again, and you can vote now. So there's 2 equal leaders currently, equal to nodule diameter and 20 millimeters, both around 33% of the participants, 10 millimeter, 23%, and 5 millimeter, 10%. Okay.
So for nodules inferior to 2 centimeters, the recommendations are that one. So you have some papers saying that a margin superior to 1 centimeter is sufficient, but just to remind you, the ACCS recommendation, they say that for a tumor that is less than 2 centimeters, the margin should be at least equivalent to the maximal diameter of the tumor. And for the tumor superior to 2 centimeters, a 2 centimeter margin is acceptable. And so we know from this excellent paper of Schuchert and co-workers, although it's old, but it clearly proved that the recurrence rate is proportional to the tumor size and to the length of the margin. I put you that recent paper just to say that many surgeons, especially in Japan, consider that the examination of the safety margin is important. So this is a very complicated method where the specimen is sent to CT scan to study the margin. So of course this is a bit complicated, but it shows that for some surgeons it's an important issue. So again, if I can cite that paper from our department, we had many patients who whose segmentectomy was extended to lobectomy, because either for proven involved margin or for doubtful margin. So this is how it works during the procedure. So here is you see the yellow circle around the small tumor. So we put 2 stitches on the staple line and ask the pathologist to study by fluid section this staple line. But you can also have an ID on the preoperative modelization. So on the software we are using, we have put a virtual margin here in yellow. A couple of examples. So this patient on regular CT was planned for a right F3 segmentectomy, but it shows that the safety margin is also on the middle lobe. So the final procedure was A3 plus S4. The same if you plan a lingulectomy. Sometimes it's difficult to know whether it's really in the lingula or in F3 or in between. So here are examples where the safety margin is between F3 and the lingula, and of course you have to extend the segmentectomy. Same for this small tumor between S9 and S10, where you have to remove both segments. Interesting is that if you are using near-infrared imaging with indocyanine green, as shown by the Weil-Heiner and co-workers, usually when you do that, the intersegmental plane is much larger than what is planned by the surgeons. So this is another factor of security when you are using indocyanine green. An example here, you are performing an S6 segmentectomy. You see the line that was made by the clamp before applying the stapler. When you inject indocyanine green, the true line is that one. So finally, the specimen is more important than what was planned by the surgeon. Third issue is, what about these patients who are suspected to have spread through air spaces when you plan to perform a sublobar resection? Is it an issue? So my question is that one. The presence of stays is a factor of recurrence, whatever the type of resection. If there is a STAS, there are more recurrences after sublobar resection than after lobectomy. If STAS is present, there are more recurrences after wedge compared to segmentectomy. Or fourth possibility, it's not clear, it's under investigation.
So the poll is published and you can vote on it. So we have a majority that the presence of STAS is a risk factor for recurrence, whatever the type of resection, with 32%, followed by still under investigation. And 26% say there are more recurrences after sublobar resection than after lobectomy. And 14% think that wedge resection is more inflicted with recurrence than segmentectomy.
Well, I think the correct answer is that one. We don't know exactly. There are many controversial results. For instance, this one showing that, of course, you have more STAS when the tumor is larger. So there are more STAS in a CT1C than in a CT1A. But the recurrence and the effect on survival is only true for patients operated on by wedge resection. This paper didn't show any significant difference between lobectomy and segmentectomy for patients having STAS. And this recent paper showed the contrary, there are more recurrences in the sublobar group. And what is interesting in this paper is that the authors say that STAS can be studied by frozen section. This is not something we are doing in our hospital, but we have to study this possibility. And the fourth question in terms of oncological results raised by these two trials, is there any difference according to the type of segment that is resected? Maybe you know this paper that was published last year by Gregory Jones, showing that out of the different segments, segment 6 has poor results. It's not really explained why. Maybe I have a small explanation that some tumor of segment 6 are actually at the basis of the segment. And if you don't have a preoperative model, or if you don't study the margins by frozen section, you may be too close to the tumor. And sometimes you have not only to remove segment 6, but remove segment 10, or at least segment 10A. In addition, very frequently there are lymph nodes at the basis of the segment 6 artery. And of course, these lymph nodes have to be examined. Final question I wanted to share with you is the problem of this new surgery that is very challenging. I mean, not when you are performing wedge resection, but when you are performing some complex anatomical segmentectomies. And that may change a little bit thoracic surgery, because it raises the question of experience and volumes. So I think that we will all agree that the change from open lobectomy to closed chest lobectomy has been a bit steep, but finally we all perform closed chest lobectomy. But the step between thoracoscopic lobectomy or robotic lobectomy to closed chest segmentectomy is very high and very steep. So you can be a master in lingulectomy or S6 segmentectomy, but this doesn't prove that you will be a master for when you perform those kind of complex segmentectomies. So if you do that just one case per year, this will be quite difficult to be proficient. And we all know from several studies that the more you operate, the better are the results. Here are the results for segmentectomy, showing the differences in mortality between low volume center and high volume center. You see that it is very different. And in this very recent study that is still ahead of print, showing the issue of high volume centers performing segmentectomies, you see that in the high volume center there are more lymph nodes examined, the margins are larger, and the overall survival is better. So I come to my conclusion, and I show you again this slide that I presented at the beginning of the presentation. So I think we can change a little bit this slide, change the words, and change pneumonectomy to lobectomy and lobectomy to segmentectomies, and we will have our conclusion. So the impact of JCOG 0802 trial is that there is still place for lobectomy for CT1C tumors, but for peripheral CT1A and CT1B tumor, despite the higher rate of recurrence, we have to perform a segmentectomy, provided that we apply strict oncological criteria. Regarding the CALGB trial, we have to wait for the very final results. So far, the message we have is that wedge could be equivalent to segmentectomy, that is equivalent to lobectomy. Probably you saw that interview of Nasser Al-Turki on CTSNet, and the title is a bit surprising. knowing that 60% of the patients were operated on by wedge. And if this is true, of course, it questions what we have learned for years. So we have learned that lobectomy has a better survival than wedge resection, that wedge resection exposes to local recurrences, that margins are important, and that the number of removed lymph nodes is low in wedge resection and impacts survival, not to say a word about STAS. So, of course, if ever this is true, that we can perform just a wedge resection, that will change radically surgery. So far, until we don't have the final results of this study, the message sent by this trial is a bit questionable, because not all the surgeons will master anatomical segmentectomy, and they might be tempted to perform just a wedge resection. So at the time of this webinar, I think we don't know exactly where we are going. And because we don't know where we are going, I think for a couple of months or years, we must be stuck to the results of the JCOG. That was all. And if ever you want to learn more, you can join us in Paris in January. You will be welcome. Thank you very much.
Thank you, Eric, for this. Thank you, Dominique, sorry, for this excellent overview. I think it still is a controversial topic. If you look at the comments coming up in the chats and questions, and so I think to start the discussion, if you compare the two trials, as you mentioned, the North American trial is not yet fully published, but nevertheless, we know from the data, both regarding the demographics of the included patients as well as the outcome, that these are different patient populations. Could you comment on that and whether this can be really compared? Because with the North American trial, the overall survival was about 10 to 15% lower, and the disease-free survival about 20% lower compared to the Japanese trial.
You're absolutely right. This is something I forgot to mention. So in the American trial, most of the patients were smokers, which is not the case in the Japanese trial. And also the pathology of the nodules were not the same. I mean, there were a number of squamous cell lung cancer in the American trial, which is not the case in the Japanese trial. So you're right, it's not the same. But the rate of recurrence is very problematic, even in these patients. So I think this is important to wait for the subgroup analysis.
You very much focused on the lymph node dissection. If you look at the CALGB trial, you can see that the recurrence rates and the overall survival is completely comparable in both groups so far. And a complete proper anatomical lymph node dissection could not be done in the cases of the wedge resection, which actually comprised the majority. There were 200 wedges versus 129 segmentectomies. So how would you argue that in view of these results, segmentectomy is still the preferable option?
You mean preferable compared to wedge? Just simply because, well, of course we don't have the final results of the CALGB, but I think we are obliged to trust the Japanese trial, and also we have to trust all the papers that have been published, all the studies that have been done on the importance of lymph nodes, not only in terms of number of lymph nodes retrieved, but on the location of these lymph nodes. And so I don't see how it's possible to perform an intersegmental lymph node dissection and even an interlobar lymph node dissection when you perform just a wedge. So there are two solutions. Either what we have learned during 20 years is incorrect, it's not true, so lymph node dissection has no importance, or it's true and there is a problem with the CALGB. So I don't know, I'm unable to answer that question.
There was a question from David Gomez de Antonia. He's asking you whether you think that the 3% better survival for segmentectomy in the JCOG compared to lobectomy is really clinically relevant, particularly when you're looking at the different causes of death among the groups and the higher local recurrence rate in the segmentectomy group.
This is something, I agree, this is something which is hard to understand. So, of course, the first reaction is that these patients who have recurred, they had chemotherapy or immunotherapy, which was efficient. And so finally, the impact on survival was limited. But I have no explanation, and I'm not the only one. I mean, this is a question raised by this study.
There are some other comments in the chat, and David Waller is asking about the margins you were talking about, and the question was sort of whether you're talking about what he calls outdated dogma that removal of more lung tissue to treat systemic disease, meaning positive lymph nodes, that this is not up to date anymore, probably with regard to the medical treatment options you have. So what do you reply to this?
Hello, David. Well, I don't agree at all. If ever I'm operated tomorrow from an early stage lung cancer, I would prefer the surgeon take some time and be careful to have a large safety margins rather than having a chemotherapy, because at final pathological examination, the margin is doubtful. So if we can avoid this adjuvant treatment, I think that's preferable. No, I think it's obvious. No?
One issue you mentioned particularly in the beginning, that you're not touching it because it probably goes beyond the time frame, but could you just say a few words on the preservation of lung function by sublobar resection, whether this really brings any benefit compared to lobectomy, or whether no benefit can be seen, as it has been suggested by Eric Lim in the chat.
Okay. Can I share my screen again?
Sure.
So this is the results of the JCOG trial, showing that there was a significant benefit in terms of FEV1 in the segmentectomy arm, but the Japanese colleagues have been somewhat disappointed. They expected a larger benefit. If you look at several studies, most studies show that there is a benefit in terms of segmentectomy. By segmentectomy, we will take it as the definition of the Japanese trial. That means removal of one segment or two segments, not three segments. So this means that in Japanese trial, for instance, trisegmentectomy of the left upper lobe was not considered. Now, I skip these studies just to this point. is that we are focusing only on FEV1. So we conclude that in terms of loss of FEV1, there is not a big difference between segmentectomy and lobectomy. The issue is that probably we are wrong, and there are other factors influencing the postoperative pulmonary function. For instance, that one. So this is a patient who had a segmentectomy 1+2. So you see the place that is occupied, the space that is occupied by the remaining segment 3. And if you look at the reconstruction, the modelization 3 months after surgery, you see that this lung looks almost normal. And that brings us to this Japanese study showing that after segmentectomy, not only there is a preservation of the FEV1, but the function on the operated lobe is better. They have shown this by perfusion scintigraphy. And this is something we haven't done, but which deserves to be studied, because I'm quite sure that FEV1 is not the only factor. And we know that when we are performing, for instance, a right upper lobectomy, we expect the patient to lose something like 50% of FEV1. And when we perform pulmonary function test 6 months after surgery, sometimes the test is the same, has not changed so much, or we just have a loss of 3 or 5%. So there are probably other factors, and one of the factors is the preservation of the mechanics of the remaining lobe. So this is not something I can prove, but I think it deserves to be studied, and it's probably not the only factor. And when you look at the chest X-ray after a lobectomy or a segmentectomy, it's not comparable. So this has probably a role.
Okay, and it was also shown in the Sevelo T1A trial that after segmentectomy, the recovery of quality of life was faster compared to lobectomy, but still in the large trials, the lung function decrease or difference was defined as clinically relevant in case the difference was more than 10%, which was clearly not met. So that's going to be an interesting issue, which will, which is probably not fully solved yet, I think. Another question that came up, and I think is also relevant for a lot of participants, those were 2 trials performed in a very well-defined setting with clear frozen section requirements that differ from clinical routine probably in the majority of departments. So what do you think for the time being now, the conclusions that can be drawn already for clinical routine are, and sort of a take-home message for the participants?
Well, I think my take-home message will be the one of my conclusions. So far, we have to trust the Japanese trial. It means performing segmentectomy rather than a lobectomy for CT1A and CT1B tumor, provided we respect strict oncological criteria. One of the questions I'm unable to answer is for the surgeons who are not mastering some of the segmentectomies, and in that group I include ourselves, because even we have some experience, there are some segmentectomies we find very difficult. So for those with limited experience, is it better to perform thoracoscopic or robotic lobectomy or an open segmentectomy just to preserve lung function? I don't know. I don't know how to answer that question. But my recommendation is, as much as possible, perform a thoracoscopic or robotically assisted segmentectomy, but apply good criteria. That means true lymph node dissection, if possible with frozen section, and study the safety margins.
And regarding the margins, what would be your recommendation? To look at the margin at the pathological specimen, or the margin that would be achieved on the inflated lung?
Good question. I must say that in the department, we don't do that on an inflated lung, but you're probably right. This is safer. I have also to say that frozen section is not 100% reliable. I remember a patient where the pathologist at frozen section say the safety margin, the margin is healthy, and 2 days later he called and said, no, I'm sorry, it was invaded. Fortunately, this patient could be reoperated. But this is just to illustrate the fact that intraoperative examination can also make some errors. But it's better than nothing, and I think it should be done. You're right, probably on inflated lung.
You mentioned STAS as an important factor, which was actually not covered in the trials. Is this something in your routine clinical practice you're evaluating during frozen section, or only on the definitive specimen?
So STAS is now mentioned in all final pathological reports, but we don't study it at frozen section. This is something we have to discuss with our pathologist. Despite this article I presented to you during the talk, it seemed that pathologists find it a bit difficult to prove it at frozen section.
Yeah, I agree. This is something that has been mentioned in the report, for example, also from the Memorial Sloan, that it can be done, but I think it's not widely established in clinical routine. Okay. Well, I think there's we've covered the majority of the topics raised in the chat, and I think probably some new guidelines from the ESTS will also come up during the spring or summer of next year, and will be interesting once all of the trials have finally been published. And I'd like to thank you very much, Dominique, for this really excellent overview and informative talk, and also to all the participants for the great discussion afterwards. And I'm looking forward also to our next webinar with Professor Paolo Cardoso from Sao Paulo on the 21st of November. And it would be a pleasure to welcome many of you again on this occasion. Thank you very much, Dominique, again. Thank you to all the participants, and I wish you a great evening.
Thank you very much. Have a nice evening. It was a pleasure to be here.